Welcome everyone to today's webinar. My name is Jose Francisco, Project Manager at the IAS-USA. Today's webinar will be going HIV and mental health, psychiatry and depression. I'd like to welcome today's speaker, Dr. Francine Cournos, Professor of Clinical Psychiatry at Columbia University. Welcome, Dr. Cournos.
Thank you so much, Jose, and thank you everyone in the audience who's joining me today. I hope you'll find this webinar informative. Before we actually begin the content of the webinar, I want to mention that this webinar is eligible for 1.25 credits of CME. I want to also thank various supporters for this webinar. They're listed here, and we're grateful for the help they give us in bringing you these presentations. And we have not only CME credits, but the same 1.25 credits toward maintenance of certification and nursing contact hours, as well as pharmacy contact hours. So you will have instructions for claiming credit emailed to you if you are a pharmacist, I think. Just to explain this webinar, we're going to have some poll questions. I'm sure many of you are already familiar with them. There'll be a separate window to show the poll question, and you'll choose your response, and the responses will be displayed after the poll closes. If you want to submit a question, please use the Q&A button. When you submit, you need to include your first and last name. And if for some reason I haven't gotten to your question, either I'll stay on a little late or you can email me. So let me start with my first poll question. Do you currently screen for depression using either the PHQ-2, the PHQ-9, or yes, you screen, but you start with the PHQ-2, and if that's positive, you administer the PHQ-9. You screen for depression, but you use a different instrument. You don't screen for depression, or this doesn't apply to your job. So if you would please answer this question, thank you so much. And it turns out that a very small number of you use the PHQ-2, a fair number, right? 30%, that's the most, use the PHQ-9. And then some people do that two-step process, which is perfectly acceptable to do either that or the PHQ-9. The two usually need some follow-up with a different instrument. So there's a group of you doing that. You don't screen, or you have a job where it doesn't apply. Well, that helps me understand what you're doing. And I'm going to, in fact, focus primarily in terms of screening on the PHQ-2 and the PHQ-9, and I'll talk about why that is. So now I'm going to get to the content of the webinar, and I'm going to be describing the differential diagnosis and management of depression among people with HIV. I'm going to look at how to develop strategies for managing some of the comorbidities that commonly complicate the treatment of depression in people with HIV, mostly with an emphasis on alcohol and substance use disorders. And then I'm going to review briefly some of the models for integrating the treatment of depression with HIV care and how to think about what model will best fit your treatment setting. So here's my first case-based question. Mr. B is a 35-year-old man who was first diagnosed with HIV infection 4 years ago, and he's adhered well to his antiretroviral medication regimen with consistently suppressed viral load. 2 months ago, Mr. B's partner broke up with him. And at his visit today, he tearfully talks about how sad he's been since then and how difficult it is for him to concentrate at work. You administer a PHQ-9 screen for depression, which shows severe depressive symptoms. Mr. B is amenable to taking an antidepressant medication. Which of these statements is not true? A, If Mr. B is having an episode of major depression, an antidepressant will have a 1 in 3 chance of achieving remission from his depression. Choice B, if Mr. B takes an antidepressant, he could develop mania. Choice C, a diagnosis of major depression can be made based on Mr. B's high PHQ-9 score. Choice D, a trial and error approach will likely be needed when selecting an antidepressant for Mr. B. And choice E, if Mr. B improves on his antidepressant but still has symptoms, adding psychotherapy may be a good next step. So you're going to answer which of these statements is not true. Okay, so the majority of you, 29%, said the not true statement was a diagnosis of major depression can be made based on Mr. B's high PHQ-9 score. And then the second highest answer here is that if he takes a depressant, he could develop mania, as a statement that is not true. Okay, and we'll come back to that at the end. Now we have one more question. Miss A is a 29-year-old woman who has just been diagnosed with HIV infection. On intake to your clinic, Miss A has a CD4 cell count of 180. So you're concerned about her already advanced disease. Screening assessments show Miss A currently has both severe depressive symptoms and high daily alcohol consumption. You want Miss B to have the best chance of achieving and sustaining viral suppression. So you decide an optimal approach is to begin antiretroviral treatment while simultaneously, and here you're picking the answer that is true, A, beginning treatment for her alcohol use disorder with an understanding that Miss A's depressive symptoms are likely to improve once she's drinking less. B, offering an adherence intervention while mapping up an approach to treating Miss A's depression and heavy alcohol use. C, beginning treatment for Miss A's depression while taking a harm reduction approach to her alcohol use. Or D, simultaneously beginning optimal evidence-based treatments for Miss A's depressive disorder and her alcohol use disorder. So please vote for the optimal way to begin. So the most popular answer was simultaneously beginning optimal evidence-based treatments for Miss A's depressive disorder and her alcohol use disorder. Okay, so we are going to come back to both of those questions and discuss them further at the end. This is the estimated prevalence of psychiatric disorders among people in treatment for HIV. This came from a textbook chapter that I did. And you'll see there's quite a wide variation, and it depends on what time frame you're looking at and what you're using. But I just want to say with regard to depression, it is one of the most common disorders. Probably on average, sites in the US report about a 30% rate of depression. But it varies a lot depending on what population you've sampled and what technique you've used for sampling and screening and what cutoff score you decide on. So that helps to explain some of that large variation. And you can see how common other psychiatric disorders are as well. I've been working in HIV since 1983 at the interface of HIV and mental health. And it's been wonderful to see the progress we've made in treating HIV infection. And I wish I could say that we've made comparable progress in treating depressive illness, but we haven't. So we are still left with treating depressive illness more through trial and error and with more uncertainty than we currently have in treating HIV infection. And that is because psychiatry still has no usefully clinical biological tests to diagnose depression. We have nothing the equivalent to detecting HIV or its associated antibody responses. So if you think back to the beginning of HIV, before there was even an HIV antibody test, that's sort of where we are with depression. We're still trying to figure it out based on patients' reports and, signs and symptoms that we observe. We also have no biological tests for selecting antidepressants. We don't have a phenotype or a genotype, resistance testing. We don't know which one is going to have the least toxicity and the most therapeutic response in a given patient. And therefore, we're going to have to use trial and error. For these reasons, the idea that it's simple to screen for and treat depression is not yet true. It would be wonderful if the day came when this is the case. I console myself as a psychiatrist by saying that the reason why we psychiatrists are willing to work under such trying circumstances is that the brain is nonetheless the body's most unique and least understood organ. No one's brain looks like anybody else's brain in terms of how the mind functions or the synapses in it. So we have to trade off the lack of precision in our treatment for the uniqueness of doing psychiatry. The primary reason to treat depression is not to improve HIV outcomes. I used to try to focus my talk by saying, this is why you're doing it, but it's not really the most honest reason, and it's not the most patient-centered reason. We have to treat depressive illness because of the severity of suffering it causes. It is one of the most frightening and disabling of all illnesses. And I have two quotes for you. One came from Dante's Inferno, as translated by John Ciardi. Dante was born in 1265, and the first version of the DSM was born in 1952. So Dante has no official DSM diagnoses, but his descriptions of depressive illness are extraordinary. So he starts out the Divine Comedy by saying, midway in life's journey, I went astray from the straight road and woke to find myself alone in a dark wood. So he presents it as his journey. And there's one line that's really quite famous in terms of a description of depression, in which Dante says, I did not die, and yet I lost life's breath. Imagine for yourself what I became, deprived at once of both my life and death. That to me is a remarkable description, because it is true that with severe depressive illness, you neither feel alive nor dead, although you're contemplating the possibility of being dead, even if you're not suicidal, that maybe it would be merciful. This is a terrible state. And for those of you in the audience who've had depression, you'll know that in many ways, it's a condition that transcends ordinary human experience. It's an altered state of mind that, if you've never had it, is hard to fully understand. It's a state in which there is no escape. And here's a more recent quote from Andrew Solomon, who wrote The Noonday Demon. This comes from an article in the New Yorker. I lay down fully dressed in nice clothes in the mud, and I didn't care about standing up ever again. I think this captures the physical exhaustion, the fatigue, the lack of motivation, and the feeling that it is just hard to force yourself to continue on. So the most important reason to treat depressive illness is that it gives people their lives back. Now, although depressive illness is extremely painful and very much in need of treatment, depressive symptoms are ubiquitous. They're just not the same thing as depressive illness. So we often all have depressive symptoms at times, and almost any serious medical illness or neurological condition or any other psychiatric disorder can be accompanied by depressive symptoms. So the differential diagnosis for depressive symptoms is huge. And it's important to bear that in mind, that depressive symptoms could mean almost anything. And that when we want to treat depression, we're really trying to understand who's ill with depression. Of course, that's an arbitrary point to, dividing line, as it is with many medical conditions such as hypertension and diabetes. At what line do you cross from having a normal blood pressure or a normal blood sugar to having something that's abnormal? The line is to some extent arbitrary. And as we learn more, we change where the line is. But right now, we are focused on, in this talk, on treating depressive illness and not symptoms. So even though it's naive to screen patients for depressive symptoms without understanding the broad differential diagnosis for these symptoms, doing so is a common practice. I once had a surgical procedure, and before I had the procedure, the surgical nurse read me the questions on the PHQ-9, staring at a screen. She made no eye contact, and I could tell she had zero interest in any answer. And I can tell you that I didn't have any intention of telling her whether or not anything I said to her was true about my mental state. We do this all the time now. We build this into medical records, and people very indifferently ask people a PHQ-9 screen. And I can just tell you that the more indifferent you look, the less likely you are to get positive answers. The other problem is that a positive screen cannot by itself be used to make a psychiatric diagnosis, because every screening test has a certain sensitivity and specificity. Only if the sensitivity and specificity of a screening test is 100% can you say you wind up with a true diagnosis. And I think we've seen this concern magnified in the SARS-CoV-2 pandemic, because we have such elevated rates of distress in both healthcare workers and in patients, that there's a concern about just how many people report depressive symptoms and which of those people do we really need to refer to specialty mental health care. But I want to say, although it's new in the US to see the entire population in the state of distress, because it used to be that at least if you were in a sufficiently privileged status, you could create a little world for yourself that blocked out all the ills of disadvantaged populations in the US. I've done work in sub-Saharan Africa, for example, in Rwanda, which was post-genocide, where 100% of all people, best I could tell, were in a state of extreme distress. And we've come close to understanding this through the SARS-CoV-2 pandemic. And it gives us a sense of what is it like when you can't escape from, something that's going on, that's distressing in your day-to-day life. So one of the things to think about is distinguishing between mental distress and mental disorders. So distress can occur in response to any adversity, but it often doesn't meet the criteria for a psychiatric diagnosis or require specialized mental health interventions, because distress will often respond well to supportive strategies. And I want to say that every healthcare provider is dealing with a patient's mental distress, at least at some times, and is relieving that distress through the ordinary process of being a human being with ordinary skills that allow you to explain things to people and reassure them in ordinary ways. That's a very important piece of all of healthcare. We define mental disorders as causing either persistent, severe subjective distress or functional impairment, and as meeting criteria for diagnosis in the ICD, or in the US, we mostly use the DSM, and now we're up to the DSM-5. And it's mental disorders that call for evidence-informed mental health interventions, such as medication and psychotherapy, rather than people who just have mental distress. So the two most commonly used screening tools are the PHQ-2 and the PHQ-9, and then you can do the combination. People like these tools because they're quick to complete. They don't cost anything to use or reproduce. They've been very well studied. There are lots of studies of these tools. They're available in multiple languages, although their reliability and validity isn't always confirmed in those multiple translations. And what I want to tell you in particular for using this screening tool or many other screening tools, you have a wonderful resource in the National HIV Curriculum. If you use that curriculum, and the website is at the bottom of this slide, and you go onto it, you will find that there's a section called Tools and Calculators. And the PHQ-2 and 9 are both on Tools and Calculators. And if you put in your patient's symptoms, not the patient's name, so it's confidential. If you put in the patient's symptoms, you will automatically get a score, and the score comes with recommendations about how severe the depression is and what to do next. If you're interested in learning about the sensitivity and specificity of the PHQ-2 and 9, you can learn a lot of information about that in the same curriculum, Module 2, Lesson 5. So depression as an illness is found in two types of psychiatric disorders. We used to lump affective disorders together. That's what we tended to call them until the DSM-5 decided to separate them. So there's depressive disorders, which primarily refer to major depression and persistent depressive disorders, although there are other conditions as well. And persistent depressive disorder used to be called dysthymia. Now it can also be just major depression that doesn't remit. A typical episode of major depression will last 6 to 8 months. If an episode doesn't remit after that time, you get into a persistent episode. The other form of depressive disorders are seen in bipolar disorder. And that includes mania, which defines bipolar 1, hypomania, which defines bipolar 2, and cyclothymia, which is a condition in which a mood cycles without ever meeting the full criteria for bipolar 1 or bipolar 2. So these are the most common forms of depressive disorders. I like to think of major depression as a medical comorbidity of HIV infection. Why do I call it a medical comorbidity? Because many patients will complain much more bitterly about the somatic symptoms and the affective symptoms. And you'll see that in different cultures. So for example, there are cultures where people don't have a big vocabulary for what they're feeling. And they're going to mostly tell you about pains in their body, stomach aches, things that are not really as emotional as what we like to think of as the affective symptoms of depression. The other reason to consider it medical is that it's associated with increased mortality and worse outcomes along the entire HIV care continuum. So major depression is taking its toll on lifespan. And in order to take its toll on lifespan, it is certainly affecting the way the human body is functioning. And as I've already pointed out, we don't yet have penicillin for depression. We do have some new treatments for depression, which I'll mention, which are encouraging. But for the most part, since we don't know what to give what patient, we're going to be using trial and error. And when we do that, we're monitoring two issues. One is tolerability to side effects, and the other is degree of improvement. We know that in medicine now, we're trying to move toward precision medicine, and we wish we had agents that only acted where we wanted them to. But right now we don't. They act all over the body, our antidepressants, and so they cause side effects. We also think of response to treatment as taking two forms. One is a response. One is what we call response, which is a greater than 50% reduction of symptoms of depression. But this is a less desirable outcome than remission. In remission, what we see is few or no symptoms. Aside from the fact that you can't fully alleviate suffering when you have response without remission, depressive symptoms that persist pose a risk for relapse into full depression. So the NIH had the wonderful wisdom to fund a very large study about the use of antidepressants in non-psychotic unipolar major depression. And my next slide sets are going to focus on that. What was wonderful about this study was that it was done purely through NIH funding, so there's no pharmaceutical funding and no potential conflicts of interest. It was a very large study enrolling 400 patients, which is a lot for a mental health study. And it was willing to accept people with medical and psychiatric comorbidities, because often what you'll see in trials of antidepressants for depression is people try to rule out a lot of medical comorbidities in who they accept into the sample. It was a random assignment, and there were multiple steps. There were 4 sequence steps, which I'm about to describe. And the first step for everybody who entered the study was being treated with the SSRI antidepressant citalopram. And there were the 2 endpoints I mentioned, response or remission. And if citalopram didn't work, either because the patient didn't tolerate it or because they didn't get any better, there was a step 2, 3, and 4. And I'm going to go over what those were. And since 2003, which is when the study began, hundreds of papers have been published about the STAR-D results. And I use this specific study to give me a good perspective on what we're really dealing with. I wanted to mention that step 2 of the STAR-D study allowed you to move from citalopram to a number of other antidepressants, or to just using cognitive psychotherapy. You could stop what you were using, which you might be inclined to if there was no improvement at all. Or if there was some improvement, but it wasn't enough, you might add on another option. And again, here, this slide lists the other options that could be added on. Step 3 is to do augmentation of antidepressant treatment by adding lithium or thyroid hormone. And step 4 was to switch to some of the antidepressant medications that we use less. For example, monoamine oxidase inhibitors that require a special diet. And I would have to say that the results of this study could have been more wonderful, because what we found was that in step 1 of the study, when everybody was on citalopram, only 37% of people went into complete remission from their depressive symptoms. That is to say, they had few or no symptoms. And if you look down to response rates, 49% had at least a 50% reduction of symptoms. So, you know, almost everybody got somewhat better, but that low rate of complete remission is discouraging, at least it is to me. And also, this doesn't take into account rates of medication intolerance, relapse, and dropout, because that's not what the slide I'm showing you is demonstrating. On the other hand, if you tried step 2, which was to add on an adjunct or change to another antidepressant, you again had about a 1 in 3 chance to achieve remission. So overall, if you were giving 2 adequate trials of antidepressant medication, you could get about a little more than 60% of your patients, when you take into account other factors, into really good remission from depression. That's not so terrible, all things considered, given the state of the art that we have in psychiatry. It's nowhere near as good as we do with suppressing viral load if people take their medicine. And because the first and second trial both look pretty promising, you know, from this modest perspective I'm presenting to you, it's good in primary and HIV care if you happen to be a prescriber who's willing to use antidepressants when you can't refer to a behavioral health provider, or because you've expanded your practice to do that, or because you have a family care background and you learn to do it. Regardless, it's good to know how to use more than one antidepressant so that you can switch from one antidepressant to another. It's interesting that it doesn't really matter what you switch to. Best we can tell from the STAR-D study. You don't have to go from an SSRI antidepressant to another category of antidepressant. You could just switch to another SSRI. Why? Who knows? So it's just that we're doing trial and error, and the first antidepressant doesn't work, you can try another. Obviously, if someone truly can't tolerate an antidepressant, you're going to have to stop it pretty quickly. One of the things that we like to do in HIV care and for any medically ill patient is to start low and go slow. It's better to start at a low dose so the patient doesn't have severe side effects in the beginning, because they can be very discouraging. And the more medical comorbidities you have, the more you can, experience those side effects. So it's better to start low, go slow. And then if you've gone through 2 trials that are complete trials of antidepressant medications, to refer to specialty care. Because if I go back to the slide with the response, you see that when you get to step 3 and step 4, you're talking about rates of remission and improvement that are below 20%. Okay. The other reasons to refer to specialty care is that you believe the patient might have bipolar depression, psychotic depression, and I want to say depression with psychosis carries a significant risk of suicide. If you're worried about risk for suicide and violence, or if you really feel uncertain about what's wrong with the patient, those are good times to make a referral. We've developed some new treatments for depressive disorders. First of all, the Ssri antidepressants only became available in the late 80s. So that was after HIV. And they are, and those newer antidepressants are so much easier to use than the old tricyclic antidepressants, which still exist as the main treatment for depression in many low and middle income countries. But anyway, we did develop antidepressants that are much more tolerable. We have brain stimulation treatments. We don't tend to use them very, very readily. There's electroconvulsive therapy, which was the first brain stimulation treatment. And what many people don't know is, despite all the images of how it gets used as punishment, movies like One Flew Over the Cuckoo's Nest, ECT is much more effective for depression than antidepressants. It's actually an amazing treatment. And its main problem is memory impairment that's associated with it. There's a lot of debate about how much of it is permanent. So usually it's not permanent. But anyway, we've now developed other forms of brain stimulation treatment where we're less worried about memory impairment, and that includes vagus nerve stimulation and repetitive transcranial magnetic stimulation. And TMS is used primarily as an adjunct to antidepressants. Now we've also started to play around with hallucinogens. When I did my training in psychiatry, ketamine was called Special K, and we used to see many people admitted to our psychiatric unit completely psychotic from having taken ketamine. This is a drug that's used by veterinarians for anesthesia. It's still used for that purpose. But it's very interesting to see that it's been rehabilitated as something you can give to a human because it was recently approved by the FDA for refractory depression. Refractory depression is a huge issue, with patients who are depressed. It's so draining of life's motivation. So we are trying to experiment with a lot of different things to see, can we do a better job with refractory depression? But when you're using these treatments, you want to make sure that all the safeguards are in place for using them. And we always want to see patients with refractory depression referred to the next level of care if they're willing to go, because it's really helpful to get this disorder better. One of the problems we have, and it's been well demonstrated in primary and HIV care, is it's not easy sometimes to distinguish major depression from bipolar depression. They look the same, but they're not part of the same underlying illness. Bipolar depression accounts for most of the time that people with bipolar disorders spend unwell. So that's what's tricky about it. Most people, when they present with bipolar disorder, they're presenting in a depressive phase, not in a manic or hypomanic phase. And there have been studies that show that in primary care, over 3 in 20 patients diagnosed with a depressive disorder actually have an unrecognized bipolar disorder. I always say, if you have a patient who has a label, bipolar disorder, and the only medication they're taking is an antidepressant, you really want to rethink what's wrong. Is it the diagnosis or the treatment? Because that's not a good match, an antidepressant alone for bipolar depression. The first line pharmacologic treatments for bipolar depression are mood stabilizers, and we use lithium, anticonvulsants, and atypical antipsychotics. Whereas for major depression, we're using antidepressants. And when you give antidepressants alone to people with bipolar depression, not only isn't it particularly effective against depression, but it can precipitate mania. And precipitating mania is really a crisis for yourself and for the patient. So I don't want to discourage people from using antidepressants, even with these risks, just because depression is so painful and so debilitating. We really need to do our best to treat it. And it's okay if we're not 100% sure of what the diagnosis is. We treat a lot of things empirically in medicine, even though we're no longer treating HIV empirically. Now, there are no brief screens for bipolar disorder. There's a mood disorders questionnaire, the MDQ-13, and you can find it again in the National HIV curriculum. You can just ask a few questions. You can ask the patient if they've ever been told they have, we used to call it manic depressive illness or bipolar disorder. You can ask what medicine someone's been in to see if they've been on, things other than antidepressants to gain good control. You can ask a few of the questions that are in the MDQ because some of them it would be unusual to get positive responses. Like for most people who've never been manic, they're not going to tell you that they had a period when they weren't their usual self and had much more energy than usual, or when they got much less sleep and didn't miss it. This is one of the few traits seen in bipolar disorder that one could feel envious of if we could only, achieve that. Nonetheless, it's a very difficult disorder to have. And you can't just have the one symptom you want. So we can't envy this disorder. But I just want to say, it creates an unusual state of mind that you don't tend to see in other disorders. And if you get a yes answer to one of your questions, you could decide to do the full questionnaire or to refer to a behavioral health provider. On average, bipolar disorders are more severe illnesses than depressive disorders. And that's one of the reasons why they were categorized in DSM-5 for the first time as separate from depressive disorders. It's felt that when you look at the course of bipolar disorder, you're going to see a lot more disability. You're going to see a lot more people needing ongoing lifelong management if they're going to function at their social and occupational best. And it's also one of the few illnesses in psychiatry for which we give medicine that we can show intensive psychotherapy really makes a difference in this population, primarily because people learn how to manage better. The other thing about bipolar disorder is that it is linked to an incredible level of creativity and among a subgroup of people who have this disorder. Like all psychiatric disorders, the range of possibility is enormous. From people who are totally debilitating to people who can, wind up doing remarkable things. I once went to a lecture where someone argued the point that bipolar disorder, when you're manic and hypomanic, if you're functional during it, allows you to work with incredible speed. And I can tell you that from my own experience, that people who can stay functional when they're hypomanic or manic can do the most remarkable set of things in the shortest period amount of time that those without this kind of special energy aren't able to do. So of course, people don't like to give up their special energy, even though eventually, often, they'll become debilitated by this. And they'll also, perhaps reach a point where they become disorganized in it. And I see there's a question about when the next DSM version will be released. And I would say that I don't know the answer to that. The DSM is what keeps the American Psychiatric Association fiscally solvent. But I don't know when we're going to have the next DSM. But the things that I'm saying about this are really found in our current literature. And not the part about being speedy, because you see that wouldn't. What's interesting about psychiatric disorders is that there are some special qualities people with psychiatric disorders have, but we don't consider the special qualities illness, so they don't appear in the definition of illness. Like we wouldn't put a trait like, being able to work really faster than any of your coworkers and get so much done as an illness marker, because anybody would think that's a good trait. So, when we're trying to understand mental illness, it's very important to understand that there aren't just harms and symptoms to illness. There's really also special qualities people can have. Anyway, going back to the state of being, revved and energetic, and especially if it's accompanied by euphoria, although it may also be accompanied by irritability, it's very hard to get people into care in that state. People don't like to give up that state. And we do much better trying to get people with bipolar disorder into treatment when they're in a depressive phase, which is in any case most of the time. So here are some of the exceptional people who've had bipolar disorder. We all know Edvard Munch's famous scream image, and it's been used all over the world. And this is Vincent Van Gogh's a picture, self-portrait of himself. He was also bipolar. I love the fact that Winston Churchill not only brought Britain through World War II successfully, but he had enough bipolar energy in him to write voluminously and win a Nobel Prize in Literature in 1953, which is only to say that some of the things people with bipolar disorder accomplish are truly remarkable. And I say that because mental illness is so stigmatized that we often overlook the fact that not everything about it is negative. There are some things about it that make people special. And one such person getting into our territory is Alvin Ailey. He was a renowned modern dancer. I saw some of what his theater did when I was young, and I thought it was absolutely remarkable. He was a dancer and choreographer, and his bipolar disorder was aggravated by his drinking and drug use. He died of AIDS in 1989, but his work lives on through the Alvin Ailey American Dance Theater. So he's more like some of the people we see in HIV. And he also had the dual diagnosis of both drinking and drug use. Now, how do we think about alcohol and substance use comorbidity? Psychiatric disorders carry a high degree of comorbidity with one another. And we don't really have an explanation. If we got to understand what the underlying vulnerability was for our illnesses, I mean, we have theories about neurotransmitters, but we don't really have proof of the things that we have theories about in a way that you could honestly call it, say we understand what causes these disorders. We might be able to make more sense, but if you've seen patients with psychiatric conditions, that they're often given multiple diagnoses, and these diagnoses often change over time. And that's because it's like the blind man feeling the elephant, it depends on what we're feeling at any given point. Oh, it's the leg, no, it's the trunk. And that explains why we have this kind of problem in psychiatry, because we're just such a, we have so much comorbidity with those disorders. And most people with substance use disorders receive no treatment at all. Now, this is in part explained by people who don't want to get treatment, but it's more explained by the fact that we just don't do a good job offering treatment. We don't do a good job ensuring treatment. And the combination of having bipolar disorder with addiction is a really, really challenging combination. I've managed people with these disorders. I've had colleagues and parents, friends who are parents of kids with these disorders. It's hard to get a more difficult combination than being bipolar and being addicted to alcohol and drugs. In general, depression and bipolar depression both significantly result in worse outcomes than if you have two disorders, if you have only depression, or if you only have an alcohol and substance use disorder, you will do better than someone who has both. And in a review of studies with people with bipolar disorders, and this is not specific to HIV, there was a 42% of prevalence of alcohol use disorders and significant rates for cannabis use and other illicit drug use. So these are common comorbidities. And I've already said how troublesome they are and how much they can impact on the HIV care cascade. But the most important thing, I once got a colleague of mine, Herb Kleber, who is no longer with us, may he rest in peace, to say, if there's one bottom line you can tell me about people with two disorders, what would it be? And he said, this is it. Two disorders require two treatments. And that always stayed in my mind. You cannot treat a non-addictive disorder and expect an addicted disorder to get sufficiently better, and the other way around, even though we have various fantasies about it. Usually you need two separate treatments for these disorders. If you want to know if your patient might have a substance use disorder, they're again going back to the national HIV curriculum. I don't mean to seem like an advertisement for it, but it's made life so easy to screen. You can find a number of short instruments that you can go into the curriculum, access it, run your patient's symptoms through it, and get a score. And it will tell you how serious the patient's problem may be. They used to score something called the DAS-10. That's a 10-item questionnaire. But the group that works on these screening instruments decided that 10 questions was too many. So now you'll only find it in the text of the national curriculum. So I'm returning now to this slide about mental distress versus mental disorders, but now to talk about the care system. What is the care system supposed to do, especially in light of SARS-CoV-2, with the huge number of people who are in mental distress, but the limited number of people who are available to provide behavioral health services? Before there was SARS-CoV-2, we didn't have enough behavioral health providers. Since then, we certainly don't. So as a public health measure, it's important to separate distress from disorder so that we know who's most in need of specialized care. Now, if you're a private citizen and you can afford your own care, by all means, it's great to get care for any degree of distress. I would certainly, subscribe to that, and know many a person who's been in, therapy for ordinary life problems found it very helpful. But when you're switching over to a resource in short supply, which is behavioral health providers available to people doing HIV care, you want to try to prioritize disorders. Well, what should you do with everything else? I learned the pyramid of mental health services when I was doing work in sub-Saharan Africa. And I have to say, I brought it back to help people think about mental health services in this country. I've worked on projects integrating HIV care and mental health care. And what I think the pyramid of mental health services tells you is that if you look at specialty care services, They are at the top of the pyramid. You'll see long stay facilities and specialist services, and then you'll also see psychiatric services in general hospitals and community health services, right? You'll see services in primary care, a lower rung in terms of where it belongs on the pyramid, but we are really depending a lot on managing distress through informal community care and self-care. And having spent a lifetime being this old as a physician, whether it's a psychiatric illness or HIV or any medical illness, you cannot do well as a patient with a chronic disease if you are not engaged in your own self-care. And if you're not taking advantage of all the informal means of keeping yourself well, it's just not realistic to depend on your occasional visits to a psychiatric provider to keep you well. And I want to just say that I do think we often overlook the issue of what the patient needs to do. And I'm not talking about blaming patients. I'm talking about helping patients understand just how much self-management really makes a difference. So these are all the points that I already made. And for people who have well-established psychiatric illnesses, like depression and bipolar disorder, these are illnesses that cycle in most people. So we can reduce the frequency of cycles by having people engage in self-care and informal care. And if you talk to patients in detail, you'll discover that the most articulate patients who have virtually any psychiatric disorder can tell you some very special techniques they've learned about things they can do and things they can't do if they want to stay well. Now, during the COVID-19 pandemic, we've all been bombarded with millions of pieces of advice about everything I'm talking about here: coping strategies, maintaining routine, eating and sleeping well, you name it, we've all heard it. So these are the strategies that I'm talking about and which all of you now know about. And I've already made this point. And just going back to this, I really like to emphasize that you don't want to think that you want to remember you too, as a healthcare provider, are behavioral healthcare provider. Every healthcare provider is contributing to behavioral health by reassuring patients and explaining to them what's wrong. What are the outcomes we hope for when we treat depressive illness? The number one outcome: to relieve suffering and improve quality of life. We also hope for reduced disability and cognitive dysfunction. And I just want to say that as people with HIV age, it's important to know that, that depression contributes to cognitive dysfunction. Even if cognitive dysfunction doesn't get entirely better if you treat depressive symptoms, it can improve, and the quality of life of people will definitely improve. So think about whether there is a depressive element in your patients with cognitive dysfunction. And we want to be able to gain the benefit of reduced mortality due to suicide or medical illnesses. However, we don't yet know if we can achieve improved rates of viral suppression or reduced HIV-related morbidity and mortality, because we only have small numbers of studies and they conflict. So we do know, just clinically, more than through anything else, that if we treat people with HIV for depression, we get pretty much similar outcomes to treating any group of people for depression. But we have conflicting studies about whether the successful treatment of depressive illness will by itself improve viral suppression. There are studies that say it can, there are studies that say it can't. The way I like to think about it is when you think about depressive symptoms improving, there's a step of rehabilitating people from the state that they were in when they weren't doing well. And that rehabilitation may include, in the case of people starting antiretrovirals, doing a specific adherence intervention, because we know adherence interventions can increase the improvement you'll see in viral suppression. And we're not so sure about whether the treatment of substance use disorders or depressive disorders will do that. There are many approaches to integration. They vary widely. I've given, literally, I've probably given 2,000 talks in my life. I'm going to just say very quickly that there are programs that are just the most amazing thing on earth you've ever seen, and everybody gets everything. And there are programs that have almost zero. So people have all these models of care. I'm going to show you what they are, but I'm not spending time on them. I can tell you from working in the field that these hypothetical models are wonderful, but they're very hard to implement. And you need a model that works for your setting. If you are in a rural setting, an urban setting, whatever your setting is, one size does not fit all. You have to give up on perfection, decide what's realistic in the setting that you're in, and go with that. I do think we've learned a lot from doing virtual visits during COVID-19 that would apply to integrating behavioral health care into HIV care a little better. I'm going to close with just a few reflections on why it's so difficult to integrate physical and mental health care. And I would say if there's one thing that prevents us from treating all these illnesses better, it's stigma. And it's not just stigma that's in the general population. It's here in healthcare provider education. And it's even very present in the attitudes of behavioral healthcare providers. And I think in part when people go through their training, abnormal behavior is frightening. And if you don't learn how to approach people in a way that makes you feel that you know what you're doing and you're safe, you're going to want to avoid approaching people who behave abnormally. And that is a natural impulse. But really, we shouldn't be graduating people from health professions who have no idea what to do with a person with abnormal behavior, because that could be a person who's dying of an illness and is delirious. So we have a system where most healthcare providers believe that taking care of substance use disorders and other mental illnesses is just not part of their job. But for better or worse, the brain and the body are inseparable. The brain is the master organ of the body. It tells you how fast to breathe. It informs your heart how fast to beat. It tells you what to do in an emergency. It tells you the lion is coming and you should run away. It tells you your feet are tired and you don't know if you can go any further. You know, the brain and the body are one system. And I like to point that out by showing you that the expressions for strong emotion are all about how you feel emotion in your body. Whether I love a gut feeling in particular because the neurotransmitters in the gut are extremely similar to the neurotransmitters in the brain. And so it makes a lot of sense that when you're feeling something emotional, it's also in your gut. And it's also an explanation for why Ssri antidepressants have so many gastrointestinal symptoms. If we're thinking about reducing premature death, you know, we have a healthcare system that isn't doing great. Before COVID-19, what we saw, I haven't really looked for data since COVID-19 to update you about this. But before COVID-19, we could see that the US was not doing well compared to Western European high-income countries. Our length of life started to decrease, you know, how long people live. The years lived with disabilities started to increase. And we just don't have a system in which we're doing a great job. And that's probably the reason why, when you look at what people die of in the US, 40% of it is explained by behaviors, things like smoking, things like overeating and obesity. Your genetics is less important than your behavior. And it's way less important than the medical care you're getting. So the other reason to think about how people are behaving as important when you're functioning as a healthcare provider is because this is really what's killing people, how they're behaving. So in closing, my thought is that If we could overcome the profound problems that separate the treatment for diseases of the body from the treatment for diseases of the brain and mind, such as overcoming stigma, getting away from treatment silos, licensing everybody in a totally fragmented way so they can do this and they can't do that, having a million regulations about who can see what piece of information, which is also based on stigma, this could be one step toward reversing the current trend of that we see if we spend more money and we get less good results. And now I'm going to ask you these two questions again. So Mr. B is a 35-year-old man who was first diagnosed with HIV infection 4 years ago, and he's adhering well, but now he has a screen for depression and he has severe depressive symptoms. Which of these answers is not true? And I won't reread them because you can read them and you'll remember them, right? He's having an episode of depression. If you give him an antidepressant, he'll have a 1 in 3 chance of remission. He could develop mania if he takes it. You can make a diagnosis based on his PHQ-9 score. Trial and error approach is needed, or he improves on his antidepressant but still has symptoms. You could add psychotherapy as a good next step. So let's see how people answer. Yes, look at that. That's fantastic. 2/3 of you know you can't really make a diagnosis of depression. We, though, can treat probable depression. That's not the world's worst problem, but we really can't be sure of our diagnosis. And the reason why it's important to know that is that we need to stay on our toes and see what else, evolves with the patient, to see what else could be wrong. And now if we go to the next question, this is Miss A. She's been diagnosed with HIV infection. She already has advanced immunosuppression. She is both having severe depressive symptoms and she's drinking a lot of alcohol every day. You want to start her medication right away. We're into doing that even in people who have risks for not adhering. If you wanted to adhere, what is your optimal strategy? And we had the most common answer being simultaneously beginning optimal evidence-based treatment for her depressive disorder and her alcohol use disorder. Should you be doing that, or should you pick one of the other options? Just focus on the alcohol use disorder, just focus on the depression, or offer an adherence intervention while mapping out an approach for her depression and heavy alcohol use. So most of you have still voted for the thing that you voted for the first time, simultaneously beginning evidence-based treatments for depressive disorder and her alcohol use disorder. However, that is not the right answer because we don't have evidence that this is going to, this necessarily improves adherence. Really, you need to start out someone on an antiretroviral regimen with an adherence intervention when they're at risk for not adhering. Depression and heavy alcohol use do require 2 separate optimal evidence-based treatments, but that's not the first thing you can do because these disorders are going to take a while to treat. Remember, when you treat depression with antidepressants, you get side effects before you get symptom reduction. So the symptom reduction comes later. Remember that when you treat people for an alcohol use disorder, you're going to have to go through a lot of stages and motivational interviewing to get them to a place where someone is willing to try to enter a program. You have to find a program. So if you really want to get the best possible outcomes, sadly, you have to use an adherence intervention. And now you can submit questions using the Q&A button, and I'm going to stop sharing. So my screen is open. So I'm going to take a look at Q&A. Yeah, can I explain the difference I see between bupropion slow release and bupropion extended release? It's just a different in how many, in the number of hours it lasts. I don't remember the number of hours off the top of my head, but yeah, they last different number of hours. Most people like to use the longer acting versions. Can you use gene site? And this means, is this the site for looking at how people metabolize drugs? Because I have colleagues who do use information about drug metabolism to help them decide which medications to start with. I wouldn't say it's common practice, but people who do a lot of psychotropic medication prescribing do like to use, at least some of them do like to use tests of how people are metabolizing different drugs. Any thoughts on microdosing psilocybin in depression and at end of life? I don't really have expertise in in the use of psilocybin, how people think about it now. I think people at the end of life, deserve any treatment that helps them feel better. And I wouldn't be opposed to using psilocybin. So I would say that I actually have a brother-in-law. His name is James Bacalar, who's written books on, he's spent his whole life writing about substance use. And he's one of the people who was for legalization of marijuana. He worked with someone named Lester Grinspoon. Anyway, I'm mentioning it because what good person who writes about books doesn't also try drugs, So of course he tried out all the various things you could take. And he had some amazing and wonderful trips on psilocybin. So I don't know, it may not be for everybody. Some people have an adverse response. What do I mean by an adherence intervention? I mean thinking through how to help a person adhere by doing any of the following combinations. Involving a significant other that the person is willing to, reveal having HIV to, let's say a spouse or a child that the person's living with. And, trying to get that person to help with the monitoring. Always, always, always having a pill box. Never try to remember any medicine. I don't really care what disease you have, what it is. Nothing works as well as a pill box because people get on chronic medication, get so used to taking pills that if you don't have a box that they're in lined up for the days of the week, you could swallow the pill and not have any idea whether you took it or not. It's so automatic. Having a checking in on patients. How's it going? How's it doing? And by the way, you need to check in on them with antidepressant medications because some people get immediate side effects from them. Of course, lower doses mean you're less likely to get those immediate effects, but in such a severe form. But the reason why you want to check in is that some people have extremely negative side effects to an antidepressant. You want them to have someone they can call. To say within the first few days, this medicine doesn't agree with me at all. Doesn't certainly have to be the prescriber, but it should be somebody who checks in with people because otherwise you'll start getting people who never want to try another antidepressant pill again. And I can tell you many stories like that where, let's say, older people given 20 milligrams of Prozac, which by the way is one of the longer acting Ssri antidepressants. So sometimes people want to stay away from that because it doesn't quickly clear your body. Anyway, and getting 20 milligrams of Prozac and getting a reaction that was so negative to it that they decide they would never take an antidepressant pill for as long as they live. So usually depression is a chronic condition. And usually I go for starting low, going slow, especially in our population, and trying to keep side effects to a minimum. Okay, so now when we offer HIV testing, we ask people about anxiety, depression, and suicidal ideation. If they mark a 1 to 3 on thoughts of suicide, we talk to them about whether they have a plan. What are the next best questions to determine a need to refer people to a crisis center? So there are screening tools. Columbia has one, the CCRS-5. And it lists the varying steps in which you start to worry about people. So we psychiatrists are trained. You worry depending on how close the patient has come to action. So for example, if someone has passive thoughts of suicide and they're depressed, passive thoughts of suicide are routine in people who are depressed. It would be unusual to never have a thought like, I'd be better off dead when you're severely depressed. We don't worry that that's a high risk problem that you have that thought. But we do worry as you get closer to making a plan. So the further along you've gotten to thinking how you would do it, planning to do it, giving away possessions, writing a will and giving it to a friend, it's as people take action that gets them closer to committing suicide that we worry more. We are not great at predicting suicide. There are people who very methodically plan a suicide and kill themselves that way. And there are other people who are very impulsive about suicide and their suicide attempts. And it really varies a lot. Then I see there's a question about what combinations of HIV meds and antidepressant medications should we not use? What I would like to say about that is, in general, I would say people working with patients with HIV prefer to work around what the infectious disease physician wants to do. That's generally speaking been our attitude. You and I, you go pick what you think is the best regimen for the patient. That was true even when we were using a lot of efavirenz, which had a lot of neuropsychiatric side effects. Even then that was okay, because we viewed our job as psychiatrists to let you do your best regimen and we treat whatever the consequences of the regimen are. And that was true in treating hepatitis C back in the old days when we were using interferon, which was another horrendous set of neuropsychiatric side effects. And there too, we as psychiatrists, I think in general, who work in this area at the interface of infectious disease, we're going to try our best to let you use what you want. And we make the adjustment in the psychotropic medication. Antidepressants don't have a lot of significant side effects with antiretroviral agents. So that doesn't tend to be a big problem. We get into more trouble with drugs we use for bipolar disorder, with things like anticonvulsants. So, and there we need to do a little more monitoring and, think through carefully what we're using. So I see there are no more open comments, remarks. Would anybody else like to ask me a question, even if you were just on the panel and you're a panelist? And have I left something out? I'm sure I've left many things out. So I would just say this in closing, that even though I've made it sound a little bit arduous, depression causes so much suffering that if you don't have access to somebody who's well integrated into your team to treat depression, and you're finding it very hard to make a referral, if you do your due diligence, rule out some of the most common things that can cause delirium and other forms of medical illness that can make people look depressed when they really aren't very medically ill. And you've asked a couple of questions about bipolar disorder. It's worth giving a shot to using one of the Ssri antidepressants as a first-line treatment. I would say, using sertraline or citalopram or escitalopram are the ones that most people use because they have low rates of side effects and they're easier to tolerate. They don't have a long half-life. So using one of those three is a good way to start, and then titrating up as people can tolerate it to a therapeutic dose. Can I talk about when to take a patient off an antidepressant? In general, we usually wait until someone is completely in remission, and we wait 6 to 12 months and we taper it. All psychotropic medications are like this. We always do better if we taper a medicine instead of suddenly stop it. Now, patients will suddenly stop it. In the case of SSRIs, most frequently because of the sexual side effects, which people absolutely hate and which are present in all antidepressants except for bupropion, which is the only one that doesn't have that side effect. And not everybody can tolerate that one. Anyway, so it's good to tell people, don't suddenly stop your antidepressant medication. Stop it slowly. You know, cut back on a little bit, you know, lower the dose, take it every other day, whatever, because we don't want people to get withdrawal effects from suddenly stopping. You can get withdrawal depression symptoms from it. So that's that part. If I go back to Q&A, wait. And there was one other question I thought. Yeah, I don't see that question anymore. Anyway, yeah, so I would say that, you know, if people really complain bitterly about sexual side effects, which is, in my experience, the #1 reason people go off SSRI antidepressants, you can give bupropion a try, or you could try reducing how much you're giving. We do some polypharmacy. You can reduce how much SSRI you're giving and try adding a little bit of bupropion, you know, in one of its versions to see if you can get a better, some better sexual sensitivity, and at the same time control the depression. Usually if someone's had 3 episodes of major depression, they're going to be cycling through episodes of depression. And at that point, we often recommend just staying on a medication indefinitely. I'll also say this. There are some people who, when they take an antidepressant, feel that symptoms they've had for years and years are now better. So these aren't people with only symptoms that occurred in a specific episode. These are people who, let's say, spent their whole lives ruminating over the terrible things that were about to happen in any second, or, you know, SSRI antidepressants can actually change how you think, which is a remarkable aspect of their property. So you start to lose interest in worrying about the same thing over and over again. The longer you've had certain symptoms, the more likely it is that they'll come back when you stop a medication. So the people who do best with stopping medication are the people who are lucky enough to have only 1 or at most 2 episodes of depression. And the reason why it might be better just to stay on lifetime medication is that each episode, it's believed that each episode of depression makes the brain more sensitive to getting a next episode. So you don't want to sensitize the brain in such a way that less and less stress can precipitate a new episode. You're just better off after 3 episodes of deciding, stay on your medicine. I think I've looked at Q&A. I'm happy to answer. I'm happy to stay on a little longer if anybody wants to ask me something.
I think we're ready to close, Dr. Cournos. Jose, do you have anything to move forward to close up the webinar? Thank you so much. This was an extraordinary webinar and really appreciated by our audience.
Thank you.
So Jose, why don't you take over the closing remarks?
Whoops, sorry about that. I was on mute. Thank you, Dr. Cournos. Evaluations and how to claim continuing education credits will be emailed by 5 p.m. Pacific time tomorrow, and this will enable us to review attendees that have registered for today's webinar. Here is an upcoming list of available webinars, and this is available on the IAS-USA website. For updates, please make sure to visit our website. Additionally, here's a list of 2 upcoming courses that we have. And our next course will be on May 20th. lastly, here is a list of on-demand dialogues. And for updates regarding upcoming dialogues that will be added soon, please make sure to visit our website. Again, we'd like to thank our presenter, Dr. Cournos, to the audience for your participation, and to all HIV clinicians working 24/7 to continue to provide care during this time. Thank you, Dr. Cournos, and this concludes today's presentation.
Thank you, everybody, for attending.